And they even talk about putting all the infected people out on an island somewhere. And that went on. That didn't go anywhere. This was during the latter part of the Reagan administration, and they didn't want to touch that. And that didn't go anywhere, so they didn't do any quarantine. And that has significantly spread at this time. But that's what we saw at the first time. And I don't know. There was a lot of panic where we were. People were just concerned. Mm-hmm. And the word went out to the homosexual community. Hey guys, something's going on here. We probably use some protection. But that was the early stages of it, and you saw some of the first ones there. This was 79, 80 when we started seeing them. And then people started dying, what, about 81, 82, somewhere in there.
For the two clinicians here, that in y'all's practice, what would be some observations you'd make from past years as people come in with concerns? Again, the idea of how do we reassure the public in terms of we got this, that we're yes, I'm glad that you came in, but don't panic. In other words, fear creates panic, facts create action. What have you seen over the years in y'all's practice in terms of reassuring your patients?
Well, I think patients want to know that the physician really understands what's going on. That the physician recognizes that there is such a thing as Ebola in this case, and that the physician knows what to look for and knows who's at high risk and who is not, and is able to reassure the patient with appropriate facts and would be willing to test the patient. Nobody is reassured if the doctor says, oh, you couldn't possibly have it, don't worry, because they're worried.
It's a real good point, Ann, because patients get more frightened when...
Patients get more frightened. So they want to hear what the facts are about the case that makes them low risk or high risk. And they want to know that if they are considered to be at high risk, the physician will do the appropriate tests and give them a firm diagnosis. So they want to know that their concerns are listened to and that the physician has the capacity to respond and will respond appropriately.
Mm-hmm.
Well put.
Chris, your thoughts?
Well, I agree with that, but the patients that I've talked to now aren't as concerned about, say, the Ebola outbreak as it stands today, because they're reasonable enough to know that there's only been 2 cases, and those are people who had contacted it from the first primary case, 2 secondary cases that were actually caught here or wherever, and they realize that it's a very small thing right now. They're worried about the potential for pandemic, the potential for a big crisis to happen. And I think we need to let them know in the media and otherwise that we are on top of this. We are trying to get on top of this. There were some errors made at the very first, when the first case came in. Those errors have been corrected. And that this most likely won't turn out to be a giant pandemic. And if it does, that we're going to be as ready as we possibly can be. As far as a local front, I talk to my patients about using good hand washing, trying to stay away from people who are ill, and to let me know at the earliest sign of symptoms, and to definitely get their flu shot, because and actually people are more receptive to the flu shot now. So it's actually a good thing on that regard. And I still know I'm going to be seeing patients coming into the clinic, and even very soon, starting already with nausea, vomiting, and fever. And we just have to look at it reasonably and say, where have you been? Right. Who have you contacted? And this is most likely just a viral infection as compared to viral upper respiratory or viral gastroenteritis as compared to Ebola.
Well, why do you think people, again, that sense of relativeness, what observations would you guys have about that people don't worry about the stuff that's worth worrying about and they worry about the stuff that's not as worthy of worrying about? Is it that the flu is just commonplace, that we don't think that it really is the killer of 30,000 people every year?
Well, the main thing about it is that it's much like the media. Why did the media, when you look on the media, they spent 15 minutes on Ebola out of a 30-minute time frame last night talking about Ebola? People want to hear that. It's the news. It's what people want to hear, what they want to discuss, and what they want to talk about. They don't want to talk about the flu because that was here last year and the year before. They're a little desensitized to things like that. The fact that heart disease kills so many people a year, the fact that diabetes is such a large killer, the fact that motor vehicles kill more people than airplanes. They don't care. It doesn't make, it's not good. because they're desensitized.
Mhm.
And it's your top story. It's what's relevant right now. Same thing as you use with the news. The news doesn't administer old stories. What's going on right now, and so it's relevant to them right now because that's what's going on right now. The flu season again. What did we start in September?
Yes.
That was last month. How much information have we heard about the flu? You know, in medical, yes, but it's not. It's the Ebola. That's the top. It's like that's the top news right now.
When the flu hits and we start seeing a lot more flu cases, the
Then,
hospitals are
absolutely.
full because there's so many patients with the flu. Then that will be more of
right.
an issue. Today, Ebola is an issue whether we have any cases or not. Once again, 2 or 3 cases in Dallas, Fort Worth area has. My statistics may be correct, but there's 1.5 million, 2 million people in Dallas Fort Worth area. Your chances are 1 in a million or less if you live in the Dallas Fort Worth area.
But the difference is that we have here, that's throughout history, is this is an extremely deadly disease with no known cure.
Right.
70 to 90%. The only other disease that's more deadly is the macular variety of smallpox, which has been very, very limited, and that's about 90 to 95%.
They don't know what's going to happen in a non-third world country like the United States. They're actually anticipating that if we had an outbreak here, it would only be about a 25% death rate.
Well,
But still, that's very high.
Well, that's very high, but the thing is, you know, what gets people's attention, it's like during World War I,
Right.
we had what they called the Spanish flu, even though it arose here in the United States, went through, killed huge numbers of people. The Black Death, the Renaissance started in Europe in 900. You would probably remember the frescoes that we brought here back in 2002. Those were from 900. The Black Death came through 3 times, put the Renaissance back 400 years. And these things happen, and we don't have a cure. Now, another point that's a problem here, and I think we take cognizance of, one of those healthcare workers is on a ship that was blocked by Belize last night. Okay? She's on that ship. She's got a low-grade fever. She's isolated on the ship. And the CDC said, we're going to send a plane down to your airport in Belize, and we'll transfer back. They said, no way. Nobody gets off that ship. She's not coming to the airport. We're not taking any chances. Other countries have gone and put up barriers. Ivory Coast has no cases. They're right next door. They closed their borders immediately. We have Nigeria. They had absolutely no, the last case they had was 31 August until yesterday, and a nurse and her husband snuck into Lagos and then went to their village, and she came down with it. There's 21 people there. But again, the people are afraid because this is not being isolated. You know, this is they're not being isolated. There's misinformation out there. The concept of airborne, they're talking about airborne. Airborne is something like Legionnaire's disease, where it gets in the air conditioning unit and spreads. One of the first major doc in Liberia who died, Dr. Samuel Brisbane. That was back in July. What happened? He was working on a patient. He didn't have anything over his eye. Patient coughed. He got a droplet on the eye. 2 days later, he was sick. 1 day later, he was dead. Now, does that mean hitting the eye, hitting the conjunctiva is more rapid? I don't know. But that's the situation. The Canadians, 2012, came out with a study showing that it was airborne. Until last month, the Canadian protocol for travelers was they had in there, airborne spread among humans is strongly suspected. They just cleansed that from their website. We've got the NIH monkeys, all those monkeys that they were using. Those monkeys were in separate cages, even in separate rooms, and they all started getting Ebola. And they euthanized the whole group.
Can we speak to the issue of airborne? Because I think, again, that's...
Because, again, you're getting coughed on, it's airdrop. It's airdrop.
Even if
coughing,
they threw up
sneezing, vomiting.
And it aerosolized some into the air,
Yeah.
that can get in your, especially your conjunctiva. I think would be extremely a possible transmission source.
Yeah, because they say flu 6 feet for aerosolized.
Yeah, and that's
This
the
they
cough,
say 3
the
feet.
foam from a cough can travel about 6 feet.
They say for this 3 feet, but the question is, I'm not worried that it's going to get in the air ducts. But I don't want to be sitting next to somebody who's going to cough, or if I'm on a flight from Brussels to New York and I'm sitting there for 2 hours in the flight and all of a sudden this guy projectile vomits all over my leg. I mean, what do?
Well, again, at the local level, what do we need? What would we want to reassure people about when we talk about, like, flu is airborne, but is it a different kind of understanding of flu is airborne versus Ebola?
Casual contact, like here in the office, and I come in and I say hi to you and do like that. We do think that Ebola is extremely rare to contact that way.
But
you
CDC
would
says
actually have to be coughing, sneezing, throwing up, high fevers, and these don't cause low-grade fevers. Ebola doesn't cause 100.4 fever. It causes 101, 102, even in some cases 103 fever. And these people are going to be relatively sick before they're actually spewing out enough to aerosolize and contact.
Well, viremia precedes pathology.
Correct.
You have a high virus load before the pathology that it's
But
created
there's no
catches
liquids that
up.
they're creating that are coming out of their body at that time. I mean, that you would catch in casual contact.
I think we need to go on statistics and data here and not on projections about what ought or might happen. And I don't think the vast majority of people who have gotten sick in secondary transmission have been healthcare workers, people in direct contact with
Correct.
secretions.
With large amounts of
With
secretions.
large amounts of secretions. I'm not aware of the things you're discussing about aerosolizing. It's theoretically possible, but I don't.
Los Angeles Times, 7 October. Excellent article. Some experts worry virus may be spread more
Worried, but
easily.
is there any data about it?
There's the studies in there. The NIH study with the NIH study where they had to euthanize all the primates because they were spreading by air within a closed group.
Has there been documentation of humans spread that way?
No. We
But
don't
of
know.
course it's not
Again, we don't
exact-
know. We don't know.
Well,
have-
we know what it looks. We know that the vast majority of people infected have been healthcare workers.
Because this disease has been limited to third world countries where there's virtually no epidemiology, no studies,
Correct.
nothing.
But
But
there where it
there
is
have been
epidemic,
food
there's
workers.
30,000 cases in 3 million people.
Yeah. Remember, there have been Ebola virus
It's a lot.
epidemics periodically for a long period of time that WHO has studied. This one just escaped. This is like the third or fourth big epidemic. It's just that this one is larger. So
Much
it's been
larger.
studied for a long time.
And it's gotten out of
It's
Africa.
certainly,
It's
yeah,
gotten
it's
out
certainly
of Africa.
much
That's the
better,
problem.
yes. It's certainly got a lot of,
And people don't know where to draw the circles.
well, but, I mean, as far as we know, the majority contact is with people who are healthcare workers in
Yeah.
very close physical contact with an index case, household members and healthcare workers.
And of the primary person, of 0 person, the household members, they still haven't come down with the disease, have they?
Correct.
Do we know anything
Okay.
about that?
Correct, and it's been a good, I think it's at
Been
least
2 weeks?
14 days, if
Is it-
not
it-
21
Brian,
days.
do you remember when he came over here?
21 days is the highest level.
That was
of viral
September,
infection.
wasn't
Yes.
it?
Well, they've
Yeah,
got
because they haven't, that's
incubation.
that's a good sign. I mean, that point's well taken.
Well, and again, when people come in to see me and we talk about anxiety problems, that one of the points I make is the difference between possible and probable. And that if you put somebody on a witness stand and you say, is it possible that this could be the case? Well, since anything is possible, the answer is yes. But if you raise the standard up and you say, but is it probable, going back to, is it probable that this has happened? And that's when you look at the evidence and you say, we see no findings consistent with that.
Right, and that's what we're going to have to tell our patients when they come to
Right.
our office. It's very improbable. It is possible, but it's very improbable.
Right.
The problem becomes, though, is if we do have an outbreak in the United States, a big outbreak, these are just little tiny isolated cases in healthcare workers and stuff. If we do have a big outbreak in the United States, we will no longer be able to use the have you been to Africa or been around anybody from Africa rule anymore, and then it'll be like, have you been to Dallas? Have you been to Austin? Have you been to Houston? Have you been to Lubbock? You know, and that's possible, but very improbable at this point, I do believe.
Were there any connections between the 2 Lubbock cases that we've had and the Amarillo case?
We don't have any
with-
cases
don't have
in
any-
Lubbock.
No, with the suspected. I'm
With
sorry.
suspected.
The guy
With
here
the
in Lubbock,
suspected.
the one guy here
I'm
in
sorry.
Lubbock that was taken to UMC yesterday, the day before, was on the west coast of Africa. Came from the west coast of Africa. He had just recently arrived and was having some fever, but he had some other prior medical problems. And they ruled him out because they don't have it on the Ivory Coast.
Right, that's
And
totally.
sent him home.
No.
Truly just ruled that one out. The guy in Emerald was the same kind of situation. It was just he was having some, my understanding was that he was having some gastrointestinal problems, and said, I've got Ebola. And it was, maybe a lot because of the hype that's been going around it, that he was sick and he thought he had Ebola.
Because when somebody comes in your office and comes up to your desk, and says, hey, I think I've got Ebola. I mean, to me is the question, what is the appropriate way to respond? You have to, I think the two of you who see patients are going to have to, or Brian, I mean, somebody can come in here and say,
Sure.
I've got Ebola. I'm not trying to be anything other than practical. What's the response? Because this is going to happen.
Oh, it's going to happen.
Because, Brian, you understand this. People are scared.
We'll
It's
treat
going to
them.
happen.
We'll treat them. I mean, it's
Yeah.
just like the AIDS, when we had AIDS.
Yeah.
And just with hepatitis C and hepatitis B, we don't turn these people back, and we try our best. I have some impermeable gowns, but they're not hazmat gowns, but they're impermeable, and gloves and stuff. And if I thought somebody truly had Ebola, I would probably isolate them in one of my rooms. And I probably would contact the Department of Health and do everything we could to
Right,
isolate.
but it's important to realize we don't think the other people in the waiting room are at risk.
No, but the other,
Might want to get them back quickly.
you want to
know.
quickly
Well, you want to
do it.
quickly
You
assess
want to have
the
a
problem.
plan so the people at the front desk don't faint.
Right.
The big problem I had when I was in practice, somebody come up to the front desk with a nail sticking out of their eye. Go up and down, up and down. The first thing we had to deal with was one or two people at the front desk fainting.
Well, yeah.
Until we got the patient back. But again, this is different because, a nail in the eye is an isolated thing. I take it to the operating room, I fix it. But we got somebody coming in saying Ebola. I mean, what happens to your patient
Well, the
population?
truth is pediatrics deals with contagious patients all the time. I mean,
Mhm.
they're our front line for contagion. And many pediatric offices have a protocol where patients who are suspected of having a contagious disease go in through the back door,
Okay.
so that they don't expose the patient group, so that, people, because
So they call in
patients-
advance.
Yes, because patients have been suspected of infecting other people in the pediatric waiting room. Now, that's not the adult waiting room.
Yeah.
That's the pediatric waiting room. When you have, if you think it's measles or chickenpox,
So what if somebody calls 911 here, or someone calls the physician office and says, I got these symptoms, I think I might have
Then you
Ebola.
send them to a place that can handle the
Where-
problem.
where-
UMC and Covenant Health
Both.
System are both stating that as of right now today, they're both ready to go.
So through the
Okay.
ER, would that be through the
Yeah.
ER?
Yeah, maybe
Through the
they-
ER?
Through the ER.
Through the ER, Covenant and UMC. UMC has already shown their readiness,
Yeah.
and Covenant hasn't shown their readiness yet, but they are saying at this point they're just as ready as UMC. And as far as like primary care offices, I don't know if Ann's looked into it, we can't buy hazmat suits right now, as far as I know. I talked to a guy yesterday about it, and he said they're sold out for months.
Yeah,
And so we
Yeah,
do what
very
we
few
can. And like I said, I do
companies.
have an impermeable gown that I can wear, gloves, mask, and stuff. And if I had somebody come into my office, we've already talked about this in my office. What would happen if somebody come and we thought they had Ebola? We would get them back to one of the rooms right away. We would shut that door, tell them, do not come out of that room for any reason. I probably wouldn't even let them go to the bathroom. I don't know, just give them a bucket. But
Well, the
anyway, we
bathroom would be the dangerous place.
Yes, yeah. And because they're going to come in after that, and if that patient actually truly had Ebola, my whole staff and myself are all going to be isolated for 21 days. My office is going to be closed for 21 days during the busiest time of year. They're going to come in and they're going to spray the whole place down from the roof all the way down to the ground with bleach. There's a process that they have that they're going to implement.
Do we have hazmat? I'm assuming we've got hazmat qualified teams here in Lubbock, private and private.
That's what
public.
Probably
so
what
picked
would-
up the guy yesterday, took him to the emergency room.
Probably what would happen is if somebody appeared at the front desk and walked in and said, I think I have Ebola, we'd say, go to UMC. Or Covenant if they have.
I mean, yeah, if they really walked in my
Yeah,
office and
go to a place that has,
now.
yes, that has a capacity to deal with
Right.
this,
Good
if
point.
it turned out to be the case.
And we would probably be spraying everything
I-
with bleach solution.
I work with the Community Health Center of Lubbock, and right now we've gathered all of our employees, 170 of them right now, and we're going through the protocol. You know, what is the standard protocol for safety? And this morning we discussed, you know, if a patient does come into one of our clinics, then we do have a room that's isolated where they could go in. We do have a person that is at each of those clinics that has been trained on how to put on, you know, how to put on the gown and the glove and make sure the neck is covered, and then call, you know, the 911 and get them into one of the hospitals. but that's something that we're preparing for as a primary health, is you don't know who could walk in, and then you want to also be careful with the patients that are in there, because you don't want to build a sense of hysteria, or oh my goodness, there's a nurse approaching them with gloves.
The guy who went to the emergency room in Dallas went to the emergency room. He was in the emergency room waiting room for a long period of time. He was in the emergency room, was not treated with isolation. He was sent home. He came back very sick the next time. He was still in an area out of isolation around other patients and all this other thing, and was finally put in the hospital. He was in the hospital for a period of time. Then he was put in isolation, and nobody yet he contacted so far has shown up in Dallas
And
with symptoms.
we're almost 2 weeks. The problem there, from what I understand from the people in Dallas, was it came in, the triage person put it into the electronic medical record. The way electronic medical record is set up is countries visited is several pages down. There was nothing on the front sheet to alert anybody.
Well, my point is,
in the old way, if I'd be there as a triage doc, I would put down Liberia at the top, question Ebola on the written sheet, and people would see it. But what I've been told is it slipped through because of the new medical
there was a
record.
lot of
Is that what you've heard, Ann?
I've heard that, but not reliably. Right?
Yeah.
There's a lot of casual contact there. We haven't had just a whole bunch of cases crop up.
No.
Which tells you that, I think there is potential. Once again, back to the possible and probable. It is possible that we'll have a big outbreak come in Dallas in the next week or so. That we'll have 5 and 6 and 10 cases showing up, but it's improbable.
But one question that one of you brought up was the production of hazmat suits. If we're 3 months behind, how many hazmat suits are there in the country? What is the stockpile? I doubt that many hospitals have more than a limited, relative limited.
True.
I think there were 2 companies that produced hazmat suits. It's an industrial product that privately produced that requires startup and equipment.
What about just one question before you go, Dr. Rose? With the media here, and we don't want to scapegoat you guys, but for those of us on kind of this side of it, what would we hope might change in the media's coverage of this? If we can enlist their support to kind of reduce some of the panic, how? And we're amateurs at y'all's business, but what would we like to see in the evening news? What would we like to see in the newspaper?
Well, my thing is the hope would be is that they accurately reflect what's happening. That it's accurate that yes, there are some cases and that these are very few and far between. My other hope would be is that they help the people understand not just what could happen, but what is likely to happen. What's the possible versus the probable is probably the good thing. I know how news works, and you know how news works. Big headlines make big headlines, and little headlines make little headlines, and big headlines are but after we tell everybody maybe good hand washing, just like you would for the flu or any other illness. Don't go around people who are really ill. Wash your hands really good everywhere you go. And just be as healthy as you can, because a healthy body is what's going to help us out.
Right. Plenty of sleep. But the other thing is, if you're sick, don't go out into groups.
Well, it should. I think that
isolate yourself.
Correct.
Containment. This is one of the things that they're not stressing
Don't go
about.
to work if you're sick.
Because they politicized it about, we don't need to put down isolation and isolate people. People who are sick need to stay home and away from other people and not go to school.
Right. So what we want is the news report should accurately reflect the likelihood that anybody who's sick has Ebola. So it should say that unless you are in contact, you have direct contact with somebody who has been to a place of outbreak, your chances of having this disease are minuscule. You need direct contact with somebody with people who are from a country where the outbreak is currently occurring. And list the countries.
Right.
Not everybody who's ever been to Africa, right? But I think there are 4 countries now that have outbreaks. And if you have not had direct contact with somebody who has been in one of these 4 countries in the last 21 days, exhale, you are not at risk. Right?
But also recognizing the season in which we're in. We're in flu season.
Right.
We're in flu season.
That's why we're
Right.
gonna have panic. And
Right, that's why
Right.
we're gonna have
Fever.
If you are right, if you are running a high fever and within the last 21 days you've been in direct contact with somebody from one of these 4 countries, the place, what to do, here's what to do.
Right.
Go to your emergency room, right? And so we need a quick sort of 1-sentence sound, one maximum 2-sentence sound bite about who's really at risk, and then for those people, what to do. Go to the emergency room, which has the capacity to evaluate you, and then if you are if you're not in one of these risk groups, then you are at low. This is not a significant worry. Exhale. Stay home and treat yourself as if it's the flu.
Right.
And one other question, survival, because we mentioned here survival, and I'm guessing
70%.
that in the U.S. we've only had 1 patient die here in the U.S. And here's a situation to think about. He came in the first visit, he said, I'm vomiting, I've got diarrhea, and I'm not peeing anymore. His kidneys were already shutting down at that time. So he went home for 2 days. He died of renal failure. And the thing is that's so good about being here in a civilized country is that we get this supportive care, IVs, hydration, keeping our kidneys from shutting down, which makes, I think, a whole big difference, Brian. But again, we don't know. We've only had 1 person die, so we can only guess at the death rate, but I'm guessing it's going to be relatively low compared to Africa.
We don't know that.
Yeah.
I mean, it's 70% in the 4 countries. It's the death rate is 70%. I mean, I don't blame people for being scared. You've got a infectious disease that is hitting healthy young people, with no prior illness, for which there's no cure, no vaccine, and a 70% fatality rate.
That's pretty scary.
So the only so yes, it's scary. What is reassuring is the unlikelihood that I have it.
Yes.
It's like when Dr. Shakura at the last Board of Health meeting, I think going back to people's understanding of like the flu, that he made the point of saying that at the height of the flu season last year, that it was the young and the healthy people who were most severely affected because they had the best immune systems. And so people's logic is, well, I'm in the prime of my life, I don't really need to go get a flu shot. And yet as they get the information that says, yeah, actually, because you have such a good immune system, you stand a greater risk because your immune system overreacts, if I understood what Dr. Shakura was saying. And that's why people need to not just say, well, it's like people who you meet that say, I must be healthy, I don't go to the doctor. And it's like, no, not at all. Know the facts. The media, I think, is very important to convey those facts, and then realize that you want to take the steps of which a lot of them are just the ordinary common sense things like if you're sick, don't go out, and if you're out, don't hang out with people who are sick.
Well, we should be careful because if somebody has Ebola, they need medical attention. They shouldn't stay
isolated.
home. Right. Well, but they shouldn't be isolated. They should go to a hospital and be isolated under medical care.
Yes.
So we're not asking people who are actually at risk of Ebola to stay home. We don't want that.
Right.
They need to go to the hospital. But people should first assess their risk. And the vast majority of sick people the extraordinarily vast majority of people who are sick will be at very low risk. And here's what you should do if you're at high risk, and here's what you should do if you're at low risk. If you're at high risk, go to the hospital. If you're at low risk, assume it's something else, and then we engage hand washing, health, stay home. And here's when to go to the doctor, for high fevers, etc.
Any other thoughts or questions? Anything from the media people here?
Let me toss out something on, you mentioned the flu shot. I think also people should consider getting a pneumonia shot.
Oh, yeah.
Because if you get, even if you don't have the flu, one of the big killers is pneumonia. Or if you get in an accident, or if you get cancer.
Well, remember, a pneumonia shot is only indicated for limited groups of people.
Really?
For people over 65, or for people with any underlying medical conditions, such as respiratory diseases, smokers,
I've had
diabetics.
Several people who work for me have had pneumonia, and they have no risk factors
Well,
in their 30s.
Some of those are not, well, that's true, but the indications for pneumonia vaccine are often case mortality rates. So your insurance won't pay and people won't necessarily get the pneumonia vaccine unless they're a member of some high-risk group. People over 65, people with underlying respiratory diseases, people with diabetes, people with immunocompromising or chronic diseases, and probably pediatric groups that I'm
Because
not
when they
aware of.
first came out, I was recommended because I travel.
Well,
Yeah.
it may be a travel-related illness.
And
Which I didn't
Hep
think
A,
so.
Hep B, DPT, a lot of, we've got, every year we get a number of elderly people who really get sick with pertussis. Myself, 15 years ago, I just about died.
That's terrible. Well, that's why the CDC is recommending everybody get a pertussis booster.
Yeah.
That's why hepatitis A is recommended for travel.
Yeah.
Hepatitis B and C to certain areas.
Yep.
But pneumococcal vaccine is not universally recommended.
I understand.
And so we certainly want everybody who is at risk to get it. But if we urge people to everybody go get the pneumococcal vaccine, they go to the doctors say, well, it's not indicated for you, then that's not
Understand?
An
Not
idea
the
I was
best situation.
thinking regarding the news media. Social media is so big, and I know a lot of our news stations have Facebook pages, and they are on social media. If they could perhaps even go through there as far as educating
Well, we need to direct people to reliable, informative sites.
Right, because
People
there's
want
a lot of hype out there.
People want good information. They don't want improper reassurances. That just panics everybody.
Right.
Yep. Yeah, that's what we have to be afraid of, is making sure people don't get the wrong information.
Right.
It's like when you're sitting on an airplane and they said, well, we just got a little delay here, it'll be 10 minutes. They do that every hour. And after about 4 hours, you start getting, why aren't they leveling with me? Why don't they just say, hey, we got a delay? The same thing here. Just tell people
Just
the
tell
truth.
people the facts.
Tell people the facts. Tell them that this is what's going on. And then they trust the government and they trust the healthcare providers if they've got the facts.
Right.
Because no matter how bad something is,
That's right.
if you got the facts and you got people standing up there who they trust, it keeps down the panic, right? Don't you think, Brian?
Oh, absolutely, absolutely.
Just be honest with the people.
Have to be transparent.
Yeah.
Just be honest. Hey, we got a bad problem here, but
That's right.
this is what to do.
Okay. Anything else? And you guys have any questions, or if you want to do any kind of separate interviews?
I'm sure I'll do separate interviews, and I'm probably going to ask this, but I know Dr. Epstein, you said a lot of times what you do when you're high risk, what do you do when you're low risk? When can you assume, or I guess rightly assume, that you might be at risk for Ebola?
Well, if you have had contact within the last 21 days of anyone from Guinea, Liberia, Sierra Leone, is there a fourth country? So the countries that it would be, if you have had direct contact with within the last 21 days of a person who has just been in one of those countries, or if you yourself have been in one of those countries and you develop a fever, then you can consider yourself at high risk, and everybody else is at low risk.
Or unless they've been in contact with somebody who is in the U.S.
Right.
who's developed.
Or one of the
who's developed
two
the disease.
people that you know have had the disease.
Because the one young man that was associated with that young nurse, he was put immediately in isolation when
Well, right.
she was.
So he was in.
He probably had some close contact, and they suspected that he was at risk because of that. But being in contact with people who are known to have Ebola and would be really the only risk factor.
Okay, so there are 5 countries: Guinea,
That's what the wellness
Liberia,
service said.
Nigeria, Senegal, and Sierra Leone.
And those are all West Africa.
These are West African
African
countries.
Almost all the other countries in Africa have closed their borders at this time. They do not allow anybody from
Liberia.
those countries to come in.
Okay.
So people from other areas in Africa are not at risk. And so far, we're not, if they have had close contact with one of the one of the 3 cases that have arrived in the U.S., they're at risk. But other people should not consider themselves at risk.
Okay.
And that makes it very limited.
Yeah,
I think it's
so it's
And
lacking.
I think that's
limited.
important to stress, and I'm sure I'll ask you again just to have it secured. But I mean, I do think that that's something that we're not reporting is that
Here are the people.
here
at
are
risk.
the people who are. These are the countries. Here's the time frame.
Right.
You're either at risk or you're not.
Right, or
Which I wasn't even really familiar with all the countries that were involved. So, having that the 5 countries is really beneficial for us to put it out there.
Yes.
that's right.
All right. Well, if there's nothing else, let's go ahead and break. And then if you guys want to grab somebody in particular, Dr. Epstein or Dr. Mayer, whoever, we'll be happy to continue. Take the handouts with you. And again, let's just
Always
reassure
a
the public
pleasure.
that
I try to
wash your hands and be healthy.
And get a flu shot.
And get a flu shot.